Hello, everyone. My name is Edie Stringfellow, and I'm the Senior Director of Equity, Diversity, and Inclusion with the Massachusetts Biotechnology Council. Thank you for joining us today for Mass Bio's Makeshift Happen program, where we discuss anything related to equity, diversity, inclusion, and engagement. I would like to thank our partners, Sanofi and Pharmaceuticals, for powering today's program. I would like to go over the ground rules with you also. So for the first half of the program, it will be a Q&A portion between me and the guests, but please do not hesitate to ask questions or comments in the chat section. We want the programming to be very interactive. For the bottom half of the program, we will go through the questions asked by the audience. The program is going to wrap up around 2:40 p.m. Eastern Standard Time and a hard stop at 2:45 p.m. EST. Now let's get started. The COVID crisis has disrupted nearly every aspect of our lives. Our most vulnerable communities have been hit first and hardest by these disruptions. With an intense and intentional focus on equity, they also will be the last to recover. As resources grow scarce, states and districts must target these resources and recovery programs that prioritize our most vulnerable populations. Today, our esteemed speakers will discuss what can and should the country do to prioritize equity in the next phase of the fight against COVID-19, and how can the life sciences industry advocate for equity-focused response to COVID-19. Joining me today for discussion is Dr. Helene Clayton Jeter with Healthscape Life Sciences, Daniel Strongwalker Thomas with the Global Initiative for Indigenous Advancement, and Dr. Scott Weiss with Mass General Brigham. Let's start with Helene. Helene, please tell us a little bit about yourself and what you do.
Sure. Well, thank you, first, Edie, for the opportunity to join into this discussion with such esteemed colleagues here. I am the CEO and founder of Healthscape Life Sciences. It's a partnership network of private, public, for-profit, and nonprofit health sector partners or stakeholders. And what we do, we are champions of equitable and transformational health solutions. We draw on our collective diverse experiences to create health solutions for our clients. And our clients can include startups, life science, health plans, hospitals, you name it. We bring it given our board backgrounds.
Thank you for that wonderful introduction. Daniel, now please tell us a little about yourself and what it is that you do.
Absolutely. Hi, my name is Daniel Strongwalker Thomas. I am the hereditary chief of the Delaware Nation, Lenni Lenape people. The New York, New Jersey, Pennsylvania, Delaware, and Stockbridge, Massachusetts are our historical homelands. And my work during the days brings me to working with a company called the Global Initiative for Indigenous Advancement. And what we do is we work with communities worldwide, Indigenous communities worldwide, focused on initiatives that they need, that are identified from their community. So it's not something that people come in and tell them what they need. So it's something that we partner with them to figure out how we can best serve the community. And oftentimes when we have success, it means that we end up leaving a full-blown program up and running on its own, doing very well. So thank you, and Wanishi, for the time to be here with such educated minds.
Well, we love having you. Thank you for taking the time and be with us today. And Scott, please tell us a little bit about yourself and what it is that you do.
So my name, excuse me, thank you, Edie, and it's a pleasure to be here. So my work is, I'm a professor at Harvard Medical School and the scientific director of Mass General Brigham Personalized Medicine. And in that latter role, I'm one of the investigators on the All of Us research program and have been involved in helping recruit for the Moderna vaccine trial and for some of the other vaccine initiatives at Mass General Brigham.
Well, thank you, Scott, and thank you for bringing that up. We are grateful for everyone involved with getting vaccines to the public today and to take great care of us and get us healthy and move on to the next normal. but we desperately needed patient volunteers from diverse backgrounds for the clinical trials for this to happen. So for the next few minutes, Scott, if you don't mind, if you could please tell us what took place behind the scenes and how the Biobank and the NIH All of Us program contributed to making this happen.
So, so one of the things that's special about Moderna's trial is that they were funded by NIH, and
Okay.
NIH has diversity and inclusion milestones and guidelines that they felt the trial needed to meet. And we were fortunate that the All of Us program was on pause, and we were able to take some of our research assistants who come from diverse backgrounds and had a language capabilities that were appropriate for the Moderna trial, and actually have them work at the neighborhood health centers where a recruitment was going on. And so with the help of Pauline Chandler, who is an African-American physician at the Brigham, the Moderna team, we were able to completely change the minority recruitment and enrollment in the trial such that there was a substantial increase in the number of diverse participants in the trial. And this was in part mandated by the federal government, but the Brigham had to respond in an appropriate way. And I think there were several lessons from this. One is that it really helps if you're recruiting diverse populations where they're at. You need to be where they are. You need to have people that look like them and can speak to them directly in language that they can understand. And then if you've got leadership that's supporting that, then you're going to be successful. And this actually changed the whole tenor of the trial and actually had a dramatic impact on diversity and inclusion in that vaccine trial, which then had subsequent downstream effects that influenced the FDA's approval of the vaccine and decreased questions about the vaccine and its ability to be used in diverse populations.
Well, that makes for an excellent point when you talked about the clinical trials and how important it is to have diverse populations participate, not just for the emergency COVID-19 studies, but for all studies moving forward. So, Helene, can you elaborate on your experience? Scott talked about the FDA and talk about the clinical trial participation of minority populations. How has this shaped your response with your company in regards to how we move forward with hesitancy of Black, Indigenous, Hispanic people to get the COVID vaccination?
Yes, thanks. I want to take off where Scott led, talking about the requirements of NIH. NIH requires in their clinical studies, it's a requirement as far as diversity is concerned, having a diverse population. The FDA did not have that requirement and still does not have a requirement. We have guidance documents that urge sponsors or the entities that are running the trial to be inclusive. Not until recently with the Patient Protective Act and the Affordable Care Act was there some legislation that was stronger with increasing minority participation in clinical trials. So I wanted to, there's a little difference between the FDA regulatorily and legislatively than the NIH. And I was so happy when I read all the results of the Moderna study, the Pfizer study, to see the number of minorities in clinical trial, because during my time there, I was given the task to go out and to speak publicly about the necessity of minorities enrolling in clinical trials. So you would see me on a community level talking about how women and minorities need to participate and why. And I had to balance that with the historical information that we know that has kept people from entering into trials. But I had to balance that with where the FDA is today, where we've come from, and where we're going. And that's kind of hard sometimes to do that. And so in my company, when COVID hit, what I tried to do is think about what could I do as a healthcare provider. My education has me as an optometrist, even though my practice clinically now is mostly volunteer. But what could I do as far as for the lay people to get information out? And so we decided to come up with videos based on conversations that I was having at the time, either with friends, colleagues, about their feelings toward things around COVID-19. So the first video that we put out, they're like 3-minute videos, was basically why you shouldn't touch your face. And the media kept saying, don't touch your face. And people were like, well, why? What's the reason? And so we made a video. Then I had friends who say, well, now they say, don't touch your eyes. So we made a video. And so all of the videos you'll see on our webpage are in direct response to consumers, patients, friends, colleagues. There are questions that weren't being answered by the media. So that was one way that I thought we could do something for the community. And that's what we did as far as educating. And even my colleagues, as we put a video out, why they should adopt virtual consultations. As we know, that's another area that had slow uptake, and COVID kind of pushed us into that. And so we even had a video targeting my colleagues, my healthcare professionals as optometrists and ophthalmologists as well.
Well, thank you for sharing that story. And I'm just going to follow up with Daniel. She talked about how populations were affected. Do you mind sharing with us how COVID-19 uniquely impacted Native American communities?
Oh, absolutely. Native American communities, just like all other communities, are very vulnerable, but we're a very oral history, tradition passed on community where our elders are often our knowledge keepers, our libraries, and our historians, our genealogists, everything. And so when COVID started to hit, we, our elders were very exposed to this, and it didn't really hit Indian country right away, as we're pretty secluded. But as historically has happened, it was actually the missionaries who brought it into the Navajo community, and the Navajo community has really been affected by that heavily. Many pueblos have been brought to the point of dire needs. I don't want to use the extinction word because that's not true. We're never going to be an extinct people, but certain pueblos were brought to the point of red flags. As of now, IHS has actually distributed, I believe, close to 300,000 doses of the Pfizer and Moderna vaccine amongst their 12 areas. They're geographically located. And IHS is, for those who don't know, is Indian Health Services. Part of the treaty process with the United States government is healthcare is taken care of for us. So it's a service that we enjoy, although just like other people would say, sometimes it could be better, right? Of course, the service itself. But we're very grateful to have been part of the first wave to get this in phase 1. And I believe that about 74 to 75,000 first doses have already been given out in areas that are not on reservations. So natives who are not living in reservation settings are actually still able to get these through urban settings. And as we'll get into this more about some of the reluctancies, of course, and I think, my community as well as others have a really unique aspect on why we may be reluctant to be first in line to take a vaccine and what that means to us. So, if that's something you're interested in hearing now, or we can get into that as the conversation evolves.
We're going to get into that as the conversation evolves because it's very interesting in Native American communities and Black communities, Hispanic communities. We are going to talk more about the hesitancy, but let's talk about Scott. What's the important role of racial and ethnic demographic data in pandemic decision making? How do we get to this point?
Well, that's an interesting question. As I mentioned before, NIH had specific requirements that they placed on Lindsay Baden, who was the principal investigator of the Moderna trial, where they basically said, you need to focus on minority communities and getting representative enrollment in the trial as a function of getting the funding from the NIH for the trial. And I think that this is, I think that, race is a social construct. It's not a scientific construct. But one of the useful purposes of the NIH having these racial categories is that it can push investigators in the direction of recruitment and changing their recruitment strategies. And I think it is essential to have information about populations of all different types and how we're reaching them with regard to vaccine, how what is the impact of COVID on these communities. Daniel raised the issue of differential impact on indigenous populations. I think that if we don't have this health information, we're not going to be able to respond in an appropriate way to either mitigate the health risks or address the concerns that people have with regard to taking the vaccine. So I think it is critical to have this information, because I don't think you can plan public health policy if you don't have information about both the impact and the hesitancy that people may have with regard to treatment.
Helene, I would like for you to weigh in on that based on your experiences.
Yeah, so I agree. The only time I really feel like race should be a part of scientific discussions or discovery is for research, because it really does not define really a person. And as we found out, genetically and with personalized medicine, as the FDA, we moved further and further down that track. And I was on a lot of the work groups with that. I felt like I really don't want to use race at all, because there's so many other like demographic data. Let's look at age. Let's look at cognitive ability. Let's look at all those social determinants of health. And it's just so many things that we can look at in addition to age that may give us more information than skin color, because that's basically what we're going by. And so that's my days at FDA. So since that time, what my focus, because everything we do at Healthscape Life Sciences is data-driven, as we say, it's innovative, but I did have a keen interest in the Native American culture, because that's a part of my heritage. And when we were at the FDA, I noticed that we would have separate meetings with the chieftains, and I understand IHS and the legislative rulings that that required us to do that. But I had little issues with all the separate discussions. We had separate discussions from our Office of Minority Health. I just have little issues with those things, and Office of Women Health. So here we're going into sex and gender. I feel like it's necessary for research. So I want to amplify what Scott is saying, but I think there's so much more demographic data that we need to look at as we are even conducting research that can give us a lot more information. And Edie, if you don't mind, I wanted to get Daniel's input on just that point before I went any further.
Absolutely. Please, Daniel.
Sure. Thank you. And I'm proud to be speaking with you, Dr. Clayton Jeter. Thank you. It's interesting that you bring this up. Separate meetings for us are because we're sovereign nations. And so we do have a nation-to-nation representative with the government, which also means that sometimes all the nations are not on the same page. So I think, and I applaud the work that has gone into the constant meetings. I know IHS and the White House has been reaching out to Native nations consistently around all of this, conference calls weekly. I am the hereditary chief, but we have a terrific president who runs our day-to-day business, and she is amazing. So she's constantly battling and staying on the phone with this COVID information. But she has a double-edged sword, right? The double-edged sword is that she wants to bring what we need, and then on the other side is that our people have this traumatic, intergenerational trauma that has presented itself with this illness that's going around. So that is a double-edged sword for us in that sense. But I understand what you're saying, and I don't think any native would say we need to separate science by sex or by race or by any of these things. And I defer to the experts in this field who are in this field, who know what's going on, to give us the information and to help us with that. I think the only time, and I agree here, that this information becomes relative is when we're able to report how our communities are doing to the larger community, and we can take that information and then disseminate whatever we need the way we've learned. I think the only problem with that is historically we're not invited to that conversation, and so I am aware that the pendulum is swinging and it can go both ways, right? Too much race, not enough race. We need to find that middle, and again, that's part of the ongoing conversation. So I hope that touched base a little bit on your question.
Yeah, so
Well,
Edie, does that go back into, I don't know if your next question had more to do with health disparities, because I think Daniel brought that up when he was talking about how sometimes it's good to collect that data. And so you can see how subpopulations are disproportionately affected. Can we go further into that with the COVID-19 and maybe some of the federal responses, state responses, local responses to diagnoses and treatment? I don't know if that was one of your questions.
well, I was going to get to that, but I was going to ask Scott. Well, those are the questions I was going to ask Scott, because I think we're his personalized medicine department, he's at the intersection of the different states and the federal level, as well as in different groups. So how do we get the groups that represent, like Daniel's groups, into the conversations and talking with the people that are making these decisions? You're shaking your head.
Well, I think I think I can speak for Mass General Brigham, where we felt like we had a relationship with the state with regard to vaccine distribution, and then the state abandoned us and said, no, we're not going to go through the health system. We're going to set up our own sites to deliver vaccines. So I think this issue of reaching people is a critical question. And at the end of the day, if you're talking about reaching any type of community that feels like they're disenfranchised, you have to meet them where they are, and you have to make a special effort. And if you don't do that, you're not going to be able to gain their trust, and you're not going to be able to even get in the door to help them. So I think that I can give you one specific example. We did get a mandate from the state to vaccinate all of our employees. We have about 90,000 employees at Mass General Brigham. We're the largest employer in the state of Massachusetts, and we noticed that we were lagging behind with communities of color amongst our employees. And we had to reach out to our employees, make a special effort to communicate with some of our employee groups are not on email. They communicate solely by text. Some of our employee groups wanted to hear from their leaders amongst the employee ranks before they felt comfortable taking the vaccine. Now, at the end of the day, with the outreach and with the education, we got all of our employees vaccinated. But I'd be lying to you if I said that it was all equal across all of the different ethnic groups. It took special effort with certain groups of employees to get those people to feel comfortable with the idea of taking the vaccine. Again, the vaccine wasn't a condition of employment. It wasn't any sort of mandate. This was only the educational effort was, let us give you the facts and you have to make your own decision about whether you want to get vaccinated or not. But I would say that it's critical to be able to meet people where they are with people that they feel comfortable listening to. I would be a very poor recruiter for the Moderna trial at Brookside Health Center, which has a 70 to 80% African-American clientele, because I'm a 74-and-a-half-year-old white male. No one's going to listen to me about taking the vaccine in that community. They're going to listen to a Hispanic and African-American research assistants who speak their language, and Paula Chandler, who's an African-American physician. And those people had to work really hard, even though they were from that community, to be able to convince people to participate in the trial. So I think that, it's a lot of hard work. You have to meet people where they are. You have to be able to address their concerns, and you have to be of that community to be able to convince people to make an effort. I think those are critical things that you have to have if you're going to do this. And don't underestimate how hard this work is. This is hard work. There's a lot of effort that goes into this, precisely because of what Daniel and Helene are saying, that the people have trust issues around this, and they need facts, and they need data, and you need to be able to address all of those things directly. If you can't do that, you're not going to be successful, I think.
Well, thank you, Scott. We're actually coming up on the bottom half of the program, so we're going to open up questions to the audience. So please enter your questions into the chat section. And let's go back to Daniel while the audience is doing that, to ask you, I'm just curious, what does a public education campaign look like for tribal communities?
That's interesting. So tribal communities come in all different geographic shapes and forms. So it's really a hard blanket to cover all of Native America, if you will, or Indian country, if you will. So speaking about two specific populations, we have the urban Indian population, and then we have the reservation or home community native, because many of us don't also have reservations. We're living on lands that are not reservations, but for the sake of argument and for what everyone understands, you have natives who live on reservations, and you have natives who live in urban settings. So the natives who live in urban settings have been exposed to everything else, all the media, all of the stuff. They're frequenting all of the same spaces you and I are. They're here in Boston, where I am. They're in New York. They're everywhere, and they're very much a part of the mainstream conversation on what's going on. I'm imagining that there isn't really much of a education for specifically the urban Indian going out there. Now, the urban Indian does get the information from their tribal community, oftentimes in the form of a newspaper or of any other media that is giving out from our home nation to our citizens wherever they are. And so for my tribe specifically, what I can speak about is we are in an area in Oklahoma where we have the Caddo, the Delaware, and the Wichita together in one area. We share one space in Anadarko, Oklahoma. And so IHS, the IHS health system, is really involved and really going on, but we're really blessed enough to have something in the area in the form of the Choctaw Hospital. Now, I don't know if you know this, but the Choctaw Nation has created their own hospital. It is, I want to say about 45 or 44, sorry, again, I try to be right with these numbers. When you're saying numbers, you need to be correct. But I believe it's about a 44, 45 bed hospital. They have about 80 exam rooms, treatment center in there, everything. And so what I mean by that is they've been doing a lot of initiatives to get the information out. And so really also we have youth. See, we have this confrontation of what has happened to us in the past and the youth saying we need to move forward, right? And so the idea here is, and I'm hearing this from people like Trinity Ghetto, who's part of my tribal community at home, who's doing lots of work in this, and she's saying to tell me to remind everyone here that fellow Indigenous folks need to get vaccinated and to protect our relations. Any people in power that are on this call should support any tribal initiatives that are going on to get that information out there. And just like Dr. Weiss says, this comes from being able to hear it from your own people, from grandma hearing it from a nephew or a niece or an auntie or a cousin, from someone who has actually already gotten the shot going down. So what we're actually seeing is a whole Facebook campaign to show that we've gotten our shot, right? We're saying, hey, look, I've gotten my shot, come get yours. And I think the more leaders and the more community members that have the power, the courage to just go out there and do what they know is right to protect their communities, that starts to drip in there. But I'm grateful personally, and I'll wrap it up with this, is that I'm lucky to have a nation and a president and executive council, and that really takes this very, very, very seriously, the health of their nation. We've shut down multiple times. We've lost people just like others here. But the information is flowing, the assistance is coming, and we're grateful to all of those behind the lines who are doing the work to create all of this to get it to us. So thank you, Wanishi.
Well, thank you for sharing that. And I'm going to ask our audience who is potentially looking forward to working more with tribal communities to please reach out to either me or to Daniel. If you put your information to the chat section, I'll make sure that he gets it. And Daniel, we have a request. Is there an email or a slide deck or something you can share of your contact that you said has this information?
Absolutely. And whoever wants this can email me directly at Delaware Nation -nsn.gov. But I believe, Edie, you can help us get that information out there. And then I will connect anyone who's looking for this information to Trinity, who has all of this.
Okay, awesome. So I'm just putting my notes in here. Get Trinity's information, get Daniel's information out to the audience. And then from there, we also have another comment from, let me go back up. Someone had requested that Helene share a YouTube link as a resource that you put on your website. Would you be familiar with what they're talking about?
Yes, you can go directly to www.myhealthscape, myhealthscape.com, and then media, and you'll see everything we've produced, including the COVID-19 Why You Shouldn't series. And they're all on YouTube as well, so.
Okay, great. I see. Daniel, thank you for doing that. Because as you can see, I'm having trouble with writing and reading at the same time. Typing.
I'll do the same thing.
Okay, and then I also received a slide from MGB Precision Medicine to give out the information for their department, as well as more information for the NIH All of Us program. And we're going to get that queued up. And I'm also going to ask folks to, Helene, Daniel, and Scott, if you wouldn't mind taking a second to enter the best contact information. I think I see Daniel's information entered in. Helene, can you enter in either a link or email address they can reach you? Okay, I see that right there. And I'm going to send the slides over. So since we have about 5 or 10 minutes left in the program, I'm going to ask either Mike or Matt to queue up the slide. And while we're doing that, I'm going to ask our panelists to speak directly to the life science industry. What is it that we can do that we aren't doing to help support and advocate for more equity in regards to vaccines?
Well, I'll jump in and be the first one to take a swing at it, at least. I don't know if I'll hit the home run here, but I think one of the best things, thank you, healthcare professionals who are out there. I would ask that you bring us to the table and feel free to reach out to us. I think often that barrier of communication is sort of, who do we call? What do we do? Reach out to any FedRec nation. And one of the challenges that I actually give you is reach out and discover hospitals like the Choctaw Nation Hospital, which is tribally owned and run, and figure out if there's some sort of symbiotic relationship that can be created with you and them. I know that the American Cancer Association is interested in possibly is reaching out and trying to discover if they can have cancer research going on there. And if that can possibly happen in other industries, terrific. You know, we're grateful for the work you do, and we are just would hope to be a part of the conversation. I know that with the recent change to the term BIOPC, often what we do see is that the I in the crowd is not there. And if what I mean is that the Indigenous community is not often there. So forums like this, where we are part of the conversation, part of the voice, and hopefully I was able to plant some seeds for future communication. Wanishi.
Wanishi, thank you. Scott.
Well, one thing the life sciences industry can do is recognize how important you are, Edie, to this conversation. And I think that you know, we just need to be sure that this is a front and center in every discussion, whether it's vaccine related or care related or whatever it is, that the equity and inclusion issue has got to be at the forefront of everything that we do. And that means that everybody has to think of it and everybody has to act on it. You know, we have a huge initiative within Mass General Brigham. We're very lucky that our Chief Equity Officer, Tom Sequist, is actually a Native American. We have a special relationship with the Navajo Nation in terms of ICU care. But you know, we're doing a lot of things, but we could do more. And part of doing more is sort of recognizing that every discussion, this has to be part of every single discussion. That's the key for everybody.
I was not aware of that partnership, Scott. Thank you for bringing that up. And Matt, if you can put up the slide right now with Scott's information and all of us information, if you can let me know when that's all set. I'm sorry, Helene, please go ahead. I forgot I cut you off before making sure the slide was cut.
Yeah, I just want to bring up a little point. I really enjoyed reading The Political Determinants of Health by Daniel Dawes, and probably because I'm a part of the Health Equity Task Force down there at Morehouse College, I want to kind of piggyback on your question, what can be done? In his book, he mentioned there are three political determinants of health: voting, government, and policy. And I think the life sciences community the voting is all of us. We can get engaged and do that. But I think government is an area that life science community, because that's more of a commercial interest, that's an area that they can be a part of and kind of help. And also then policy is where we cement all of this together. And I really think life sciences, whether small or large or medium, I think you can be a part of policies. And with these policies, not just look at health or healthcare, but look at national security, economic outcomes. All these things are impacted if health disparities aren't addressed and if health equity isn't brought to the table.
Well, thank you for that, Helene. And we look forward to having Daniel Dawes on as a guest in one of our upcoming programs. And with that being said, we're coming up to the end of the program. And I would like to really thank all of our guests for joining us today. I would like to say that many cities have identified inclusivity and equity as priorities, as focusing on allocating their recovery plans, resources towards understanding and responding to their inhabitants' specific needs and context better by leveraging evidence and data. This unique moment enables them to embed support for improved inclusion, social cohesion, and equality in their work by applying a responsive equity lens to learning more about people's circumstances individually. Understanding where vulnerable people are, as Scott said, but where they're living and what jobs they are doing and what their vulnerabilities are. Empower us to engage with these communities. It begins centering their unique context to increase equity. Again, thank you, Helene, Daniel, and Scott, for sharing your insight and expertise. I would also like to thank everyone for attending and participating. And thank you, Sylvian, for making shifts happen today. For those interested in connecting with our speakers, again, I made sure that we had their information input in the chat section, and you can definitely reach out to me at any given time if you like to connect with them if you didn't see it. But last but not least, if I don't see you sooner, I look forward to seeing you on Thursday for our next program, The Obesity Epidemic, the Lack of Access and Care and Treatment. To register, please visit massbio.org/events. And everyone, please have a great afternoon. Thank you for joining us.
Thank you.
Thank you, Edie.